Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 326 of our pharmacotherapy series, which majors in diabetes mellitus. The first question refers to patient PAH whose case was discussed in parts 323 to 325 of this pharmacotherapy series. PAH is now taking insulin glargine 12 units each night and using an insulin to carbohydrate ratio of 1 to 15, that is 1 unit of insulin aspart for every 15 grams of carbohydrate, at lunch and dinner, and 1 to 12 at breakfast. She is continuing with the same high sugar pre-meal correction of 1 unit of insulin aspart for every 70 mg per deciliter more than her pre-meal blood glucose target of 120 mg per deciliter. 2 weeks later, she brings in her blood glucose records. At 7 a.m. the glucose concentration is 110 to 120 mg per deciliter. At noon the glucose concentration is 90 to 115 mg per deciliter. At 5 p.m. the glucose concentration is 60 to 110 mg per deciliter. At 11 p.m. the glucose concentration is 80 to 110 mg per deciliter. At 3 a.m. the glucose concentration is 110 to 120 mg per deciliter. PAH feels that she is now back to normal. She has no signs or symptoms of hyperglycemia, and her weight has remained stable. Occasionally, she becomes hypoglycemic before dinner, but this most often occurs when her dinner is delayed because of a hectic work schedule. Evaluate PAH's blood glucose trends. What could be the cause of her pre-dinner hypoglycemia, and how could she be managed? PAH's blood glucose concentrations indicate that her basic insulin regimen is generally adequate to achieve the overall goal of preprandial blood glucose concentrations of less than 80 to 130 mg per deciliter. The hypoglycemia PAH is experiencing before dinner could be caused by insufficient carbohydrate intake at lunch, that is inaccurate carbohydrate counting, increased activity during the day, or an excessive dose of insulin aspart, i.e., the insulin to carbohydrate ratio too high. Thus, the problem could be resolved by augmenting PAH's lunch meal, adjusting the lunch insulin to carbohydrate ratio to 1 unit of insulin aspart for every 18 or 20 g of carbohydrate, or adding a mid-afternoon snack. The next question reads, PRD, a 37-year-old man, has had type 1 diabetes mellitus since age 14. During the past 2 years, he has been very well controlled on the following insulin regimen: insulin glargine 20 units each morning with insulin lispro 3 to 4 units depending on carbohydrate intake before meals. On this regimen, his blood glucose concentrations for the past 2 weeks have been as follows. At 7 a.m. the glucose concentration is 140 to 170 mg per deciliter. At noon the glucose concentration is 100 to 120 mg per deciliter. At 5 p.m. the glucose concentration is 100 to 130 mg per deciliter. At 11 p.m. the glucose concentration is 115 to 140 mg per deciliter. At 3 a.m. the glucose concentration is 100 to 120 mg per deciliter. So my question to you is, what are the likely causes of PRD's fasting hypoglycemia? As discussed in case above, fasting hypoglycemia may be the result of insufficient doses of insulin in the evening and, possibly, reactive hypoglycemia. In PRD's case, the dawn phenomenon also must be considered. The dawn phenomenon is a rise in the blood glucose concentration that occurs between 4 and 8 a.m. after a physiologic nadir in the blood glucose concentration that occurs between midnight and 3 a.m. This 30 to 40 mg per deciliter increase in the morning blood glucose concentration cannot be attributed to increases in counter-regulatory hormones secondary to an antecedent hypoglycemic event, but it may be secondary to rising growth hormone levels. This phenomenon is inconsistently observed in individuals with type 1 and type 2 diabetes as well as non-diabetic individuals. Furthermore, it is inconsistently present from one day to the next. PRD's normal 3 a.m. blood glucose concentration indicates that post-hypoglycemic hypoglycemia is an unlikely cause of his fasting hypoglycemia. Thus, the modest increase in his blood glucose concentration between 3 and 8 a.m. may be attributed to the waning effects of insulin or the dawn phenomenon. In both cases, an increase in PRD's daily dose of insulin glargine would be indicated. Another option would be to switch PRD to an insulin pump. He has demonstrated a desire and the ability for intensive management with multiple daily injections, frequent self-monitoring of blood glucose, record-keeping skills, the ability to make appropriate insulin dose adjustments, and accurate carbohydrate counting. The advantage to using a pump is the ability to program an increase in the basal infusion rate in the early morning hours, e.g., beginning around 2 to 3 a.m. and continuing until 7 to 9 a.m. The next question reads, JVC, a 7-year-old, 30 kilograms, that is 95th percentile, 50 inches tall, that is 90th percentile girl, was brought to the emergency department by her parents because of nausea, vomiting, and a persistent stomach pain secondary to the flu. For the past week, JVC had flu-like symptoms, resulting in a 6-pound weight loss. Initial laboratory values revealed a blood glucose of 600 mg per deciliter, serum pH of 6.8 with bicarbonate level of 13 milliequivalents per liter, plasma ketone level of 5.2 millimoles per liter, and positive ketonuria. JVC was diagnosed with diabetic ketoacidosis abbreviated as DKA, secondary to new-onset type 1 diabetes mellitus. In retrospect and on further questioning, JVC's parents realized that she probably had symptoms as early as 4 weeks before her hospitalization. While on a driving vacation, she drank large quantities of juice and had to stop hourly to urinate. She began experiencing enuresis, which her parents attributed to her increased fluid intake. What signs and symptoms are consistent with the diagnosis of type 1 diabetes in a child? The diagnosis of type 1 diabetes in children is generally straightforward. Presenting symptoms include a several-week history of polyuria, polydipsia, polyphagia, and weight loss, with hyperglycemia, glucosouria, ketonemia, and ketonuria. JVC's presentation is typical for a child newly diagnosed with diabetes mellitus who is brought in for medical attention because of severe symptoms related to the flu. An acute viral illness can trigger autoimmune destruction of the pancreas and abdominal pain, which may masquerade as gastroenteritis. Abdominal pain is a common presenting symptom of diabetic ketoacidosis. JVC's weight loss probably represents fluid and caloric loss secondary to uncontrolled diabetes as well as decreased caloric intake from the flu. The symptoms of polyuria are less obvious in an infant and are frequently missed until metabolic derangement has occurred. Unlike JVC, infants frequently present with severe dehydration and metabolic acidosis despite a negative history of diarrhea or significant vomiting. The next question reads, what are the goals of therapy for JVC? Do the results of the Diabetes Control and Complications Trial, abbreviated as DCCT, apply to children such as JVC? Are there age-specific goals? Current ADA guidelines recommend an A1C goal of less than 7.5% for all pediatric groups and adolescents below 19 years old, such as JVC with diabetes mellitus. Individualization of goals, however, is still encouraged. Additional targets should also be kept in mind, including a. to achieve normal growth and development, b. to facilitate positive psychosocial adjustment to diabetes, and c. to prevent acute and chronic complications. Attainment of these goals requires a tremendous amount of support and education for the parents and can best be provided by a multidisciplinary team of professionals, including a pediatric endocrinologist, nurse educator, pharmacist, dietitian, and mental health professional. Growth serves as an important clinical indication of overall general health and well-being in children with diabetes. Height and weight should be measured at each visit and plotted on standard growth grids. If, at the time of diagnosis, a child has fallen behind in height or weight, prompt and appropriate treatment should quickly return the child to the appropriate percentile and pattern of growth. An overweight child should be encouraged to achieve a more appropriate percentile of weight gradually, over the course of several months. Although recommendations for glycemic control are based on data from studies mostly in adult patients with diabetes, achieving the same near normalization of blood glucose levels in children and adolescents is recommended. However, special consideration must be given to the unique risks and consequences of hypoglycemia in young children. A cohort of adolescents included in the Diabetes Control and Complications Trial was analyzed separately. Similar to the adults in the Diabetes Control and Complications Trial, adolescents had sustained benefits from intensive management with little further progression to proliferative retinopathy 4 years after the Diabetes Control and Complications Trial was terminated. Thus, JVC's pediatrician must strive for the best glucose control that she, her family circumstances, and currently available treatment regimens will permit. The risk of hypoglycemia is of great concern in children younger than 6 years of age, as they can have a form of hypoglycemic unawareness that results partly from their reduced capacity to communicate symptoms of hypoglycemia, but may be contributed to by less developed counter-regulatory mechanisms. In addition, food intake and physical activity are unpredictable in this age group. These factors must be taken into consideration when determining an A1C goal in this patient population, where the long-term benefits of achieving a lower A1C need to be weighed against the risk of hypoglycemia. Per the ADA recommendations, the ultimate goal is to achieve the best A1C possible without experiencing symptoms of hypoglycemia. The management of diabetes in children 6 to 12 years of age, such as JVC, is particularly challenging because many children require insulin with lunch or at other times when they are away from home. Administration of insulin at school demands flexibility and close communications between the parents, the healthcare team, and school personnel. The greatest amount of evidence-based data exists for adolescents with diabetes, 13 to 19 years. As mentioned, teenagers included in the diabetes control and complications trial achieved a mean A1C level of 8.06% in an era before the availability of rapid-acting or basal insulins. As stated previously, an A1C goal of less than 7.5% is recommended in this age group. The next question reads, how should JVC be started on insulin? Is the use of an insulin pump appropriate in children such as JVC? Generally, rapid-acting and basal insulin analogues are used in children to reduce the risk of hypoglycemia. Insulin requirements are generally based on body weight, age, and pubertal status. Newly diagnosed children with type 1 diabetes usually require an initial total daily dose of approximately 0.5 to 1.0 unit per kilogram. The small insulin requirements of infants and toddlers may be delivered by using diluted insulin, e.g., 10 units per milliliter, U10, or 50 units per milliliter, U50, to measure doses in less than 1 unit increments. Diluents are available for insulin aspart and Lispro. Insulin syringes and pens that deliver insulin in 0.5 unit increments are also very useful in pediatric patients. Most children are treated with basal bolus regimens. These regimens have demonstrated lower fasting plasma glucose levels with less nocturnal hypoglycemia versus regimens using neutral protamine hagedorn in children and adolescents. Basal bolus insulin regimens combined with carbohydrate counting are attractive regimens for middle and high school students. Because children often have erratic eating habits, rapid-acting insulins are advantageous over regular insulin because they can be injected directly before or immediately after a meal, accounting for the portion of the meal a child actually consumed. JVC should be started on approximately a total daily dose of 15 units, i.e., 0.5 units per kilogram per day, such as 3 units of rapid-acting insulin before meals and 7 units of insulin glargine at bedtime. In some patients, insulin glargine may not last a full 24 hours. In this case, the dose of insulin glargine should be divided and given twice daily, and then each adjusted based on the blood glucose patterns. Although U300 glargine or insulin degludec would last 24 hours, they are not FDA approved in children at this time. When JVC and her caregivers become skilled with carbohydrate counting, insulin kinetics, dosing insulin based on her carbohydrate intake, and diabetes management, the use of an insulin pump may be considered. The insulin pump therapy in the pediatric population is increasing rapidly as it provides increased flexibility with meal timing and has been shown to improve glycemic control and quality of life. Young children, not just adolescents, are now recommended for consideration of insulin pump therapy. Family and adult support both at home and school is critical for successful pump use until the child is able to manage his or her diabetes independently. The next question reads, where should JVC administer her insulin? Are the recommended sites of injection different for children? Does the age of the child play a factor? For infants with abundant subcutaneous tissue, injection sites are usually plentiful. For some toddlers who have lost their baby fat, locating an appropriate site for injection can be difficult. Injecting insulin into the abdomen of children with minimal subcutaneous abdominal fat or in very young children may not be advisable. Rotation of injection sites among arms, thighs, and the upper outer quadrant of the buttock or hip area, as well as the abdominal area in older children, may be beneficial. To achieve consistent absorption, insulin injections can be patterned, for example, using the arms for the morning injection and the thighs for the evening injection. Children and teens should be cautioned to not consistently inject their insulin into a single area, which may be more convenient for them. Fatty deposits and scar tissue can develop secondary to insulin action at the local tissue level. Insulin absorption from these hypertrophied areas is generally poor and unpredictable, resulting in variability in glycemic control. Insulin pen devices are very helpful for use in children because they are easy to use, have the option for an even smaller needle size, and are less intimidating. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 327.